motor exercise is superior in reducing pain and disability in patients with chronic pain, but only had a small effect. And the review reported that the larger effect size was observed in studies that restricted the patient with movement impairments. Now, this study on the screen now was performed by Farsom et al., and it's probably one of the best studies that use a classification scheme to categorize patients with movement impairment and provide an intervention according to the classification. Now, they also compare their system to manual therapy with the exercise approach, which was considered a best treatment options and probably still one of the best treatment options for patients with lower back pain. And they found that they had a statistically and clinically significant impairments in favor of cognitive behavior or classification-based the cognitive functional therapy group. And this improvement was also maintained at the 12 months follow-up period. And the large effect size was reported in the experimental group. So this study was really one of the few who really shows a large effect size, which is kind of unusual for most of the rehabilitation studies. And also it compared to very viable options, not just like a usual care or just a medication advice only. So this study is indicative that the patient with movement impairments, the certain type of exercise approach may be better. Another thing about movement impairments and OMPT is that, I don't know, maybe you encounter sometimes if you're trying to mobilize the patient, let's say neck, either patient just cannot relax or cannot let go, or trying to help you when you're trying to mobilize. A lot of time, or especially in my case, I ask the patient, can you relax? And a lot of patients say, I'm relaxed. And they don't even realize they are so girded, so tense. I think my good friend of mine, Andrew, is going to present the TMJ after me, I believe. And I also do treat a lot of TMJ patients in my practice. And this phenomenon is pretty common among the TMJ patients. They just don't even realize that they're clenching the teeth, they're tightening the neck muscles and the shoulder muscle of the trapezius. And I do believe that's part of the movement impairments as well. Because that's what they do all day long. It's probably led to the neuroplastic changes. At that point, it becomes automatic and they can't even control. Now, that can be a problem for when you're trying to provide OMPT, as you can imagine. But also, another way of avenue to OMPT is actually to ease the movement impairments or use your sort of a guided technique to work on the movement impairment. And that's also another approach that you can use with OMPT as well. So now let's talk about the mechanism of OMPT. Now, how does the OMPT work if the pain is an experience and not a sense? And that is a question and this group thought to answer with available evidence. And this group also proposed the original model in 2009 and recently updated. And the core message was really unchanged, but they gathered more evidence to support the original model. So their model has 3 zones. So they call zone 1 pertain to what happens between patient and the provider when we use OMPT. Zone 2 describes what really happens to patients when treated with OMPT. And Zone 3 talks about clinical effects. When we apply OMPT, we are providing some sort of a mechanical force or stimulus, now which are believed to produce specific mechanical effect, depending on which OMPT disciplines you subscribe to. But evidence to support such a specific mechanical effect is scant or more often evidence refutes it. available evidence seems to indicate that the mechanical stimulus applied during OMPT technique produced non-specific effect. Another important consideration in zone 1 is a patient provider specific factors. And these factors are also known as contextual factors, and it has been increasingly shown to influence therapeutic outcome, particularly in OMPT. Now, providers and the patient's belief, experience, and expectation about OMPT, as well as a clinical relationship, often called therapeutic alliance, all contributes to the contextual factors. Now, important to know here is that the contextual factors can go either way, producing either placebo or nocebo effects. In zone 2, the model describes what really happens to patients in response to the mechanical stimulus applied during OMPT. It's a bit complicated, and you can easily see lots of things happen to the patient. In summary, though, most of these effects are called neurophysiologic effect, and it is what current evidence support as a mechanism of OMPT. Now, zone 3 is about clinical effect. So pain inhibition is achieved because of a decreased pain sensitivity, enhanced pain inhibition, and decreased pain facilitation, and that often leads to clinical outcomes. Now, if you go back to my introductions about spinal manipulation, I sort of brought up this idea that the many disciplines uses spinal manipulation using the different theories, underlying theories. However, it all works. I think this mechanism on PT, it explains why that happens, because it's probably the real effect that's got not much to do, or probably nothing to do with actual mechanical effect that each discipline theorizes. Okay, and this group concluded that we believe that the traditional emphasis on a solely biomechanical mechanism of manual therapy is misguided in focus and limited in scope. And I cannot agree with this conclusion more. Again, when we talk about something like this, I get sort of a resistance from many people, almost like a denying what they have believed, practiced, or they have practiced for so many years, things that have worked for them. It's usually those theories and beliefs are fairly rooted in the biomechanical principles. But I think if you just look at the OMPT in that light only, I think its scope is limited. And the pain neuroscience really can expand the horizon of OMPT, and it really gives us a new way of using OMPT. So now I'd like to talk about OMPT in a neuroscience approach. And from here, I really have to say it's not much about evidence. I've been sort of thinking about this, practicing this last 4 or 5 years, especially after I finished the fellowship. So it's got a lot to do with sort of my own experience that I like to share. So I don't want to make it sound like this is a sort of authoritative approach or it's my approach. It's not. I'm just sharing my own experience with you. So hopefully you can take that to your clinic, try it out, see if that works. If it doesn't, maybe you come up with another way or better way. Okay, so let's start. So as I said before, every time I give a presentation like this, or talk to my colleagues about this type of stuff, first response is often, then what? Like everything we've learned was a trash or garbage. That's why I wanted to start this section, by giving this quote. You don't throw away whole life just because it's banged up a little. It's obviously neuroscience. It's sort of refuting, as well as the evidence are better, but really, start questioning what traditional OMPT practitioners, believe for a long time. But you know what? In the pain neuroscience approach, it's okay because it's really not all about techniques. Now, this system of reviews compared, it's sort of an interesting study this is. So they compare the studies, OMPT studies, and that use a pragmatic study or prescriptive study. Now, pragmatic study is like, therapists make the assessment and provide the interventions based on assessment, just like what happens in the real world. And a prescriptive design is, so basically the researchers give them, this is a technique that you perform regardless of patient condition or assessment. So that's why it's called prescriptive, right? So you get just one technique, this is what you're going to perform. Now, when you compare these two study designs, and they found that there was no difference between pragmatically or prescriptively applied OMPT for clinical outcomes. So after this system of reviews, I have come across probably a few other studies which investigate similar topics, and they all kind of come to the same conclusions. So it seems that the bit of evidence is suggesting in the same directions that probably techniques that we use doesn't seem to matter so much for clinical outcomes. But I would argue, I think contextual factors do matter, meaning that your comfort with technique, your sort of your experience with the technique, your belief about the technique, I think it all matters. I don't think you need to have hundreds of different techniques for one joint. I think if you have one or two techniques that you feel very confident and competent, and I think your patient will feel it. And by itself, that probably improves your clinical outcome through the contextual factors. Another thing that we need to be aware is the language that we use or language that we speak. First of all, the medical jargon such as slip disc, degenerative disc disease, bone on bone. Many of the biomedical languages are sort of common, and we use it in everyday practice. But I'm not sure if we give much of a thought to those language so much before we use it. That goes same for the other biomechanical jargons that we, especially the OMPT therapists, tend to use, such as instability, out of alignment, or we like to talk about many theories, which are often unfounded in a solid science, or there isn't much of a scientific evidence to support those theories, but we like to talk about it because that's the basis of our treatment. Now, the reason that I'm suggesting to stay away from those is because those words are often fear-provoking. Many of the biomechanical, biomedical language being shown to actually facilitate the fear avoidance. Now, that's why when you go back to some system review that I presented earlier, that the OMPT has no effect on the fear measures. And I would probably argue the traditional OMPT could actually have increased the kinesiophobia or fear avoidance even because of the languages that we might use. Just think about what's instability, right? So we try to apply some sort of OMPT because your spine's unstable. How does that sound? How do you think it sounds to your patient? So the spine's unstable, so it can buckle anytime. It's fearful. Okay. Same thing. It's like out of alignment. So if something's got out of the alignment and you're the only one who can fix it, and then what does the patient think? Okay, so I think our message matters. The language that we